Hello, everyone. Let's get started. And thank you for joining Heart of a Nation Disease and Medicine in Modern India. This webinar is being co organized by the Lakshmi Mittal and Family South Asia Institute at Harvard University and the Lancet Commission on a Citizen Centered Health System for India. I'm Yuvika, Program Coordinator at Mittal Institute's India office, and it's a pleasure to welcome all of you joining us from different parts of the world today. At the Mittal Institute, we work closely with faculty, students, and regional partners to deepen understanding of some of the most pressing issues shaping India and South Asia. Our work spans the arts and humanities, health, science, and climate change, with the broader goal of building meaningful connections between Harvard University and the region. One important area of this work is health systems and public health, which brings us to today's collaboration with the Lancet Commission. It is a cross sectoral initiative working towards a roadmap for universal health coverage for the people of India. The Commission released its report in January 2026. Today's session is particularly timely as India continues to face a growing burden of non communicable diseases, raising critical questions around access, affordability, and the future of healthcare systems. This discussion draws from the upcoming book by Professor David Jones and Professor Kavita Sivaramakrishnan, which traces how heart disease moved from being a relatively neglected concern in post independence India to becoming one of the country's most significant public health challenges. It also explores how the development of cardiac care intersected with questions of modernization, medical innovation, and the rise of private healthcare in India. We are delighted to have with us today Professor David Jones. Trained in psychiatry and the history of science, he is the Ackerman Professor of the Culture of Medicine at Harvard University. His research has focused on the causes and meaning of health inequalities and the history decision making in cardiac therapeutics. He and Professor Kavita have just completed a book about the history of heart disease and cardiac therapeutics in India, on which today's session is based on. His teaching at Harvard College and Harvard Medical School explores the history of medicine, medical ethics, and social medicine. Just a few housekeeping things. Please put your questions in the Q&A box. We will be monitoring it throughout the webinar. Thank you once again for being here. I will now hand it over to Professor Jones to begin the discussion.
Thank you so much for that introduction, and thank you to everyone who has joined us this morning or this evening. We will present our work in two parts. First, we will talk about the changes in heart disease itself over the 20th century in India, and then we will talk about changes in the treatment of heart disease that occurred over that same time frame. For each of these two parts, I will present some slides to review the basic narrative that we're describing, and then Kavita and I will both just describe commentary, or we'll both offer commentary on this history, and then we should have time at the end to take questions from the audience. During the 19th century, Western physicians saw India as a place of epidemics, and their attention was really focused on plague, cholera, malaria, tuberculosis, and there were many others that caused significant problems. For instance, when plague famously struck Bombay in 1896, it caused massive disruptions to life and the economy in the city. Heart disease did exist in India in the 19th century, but it killed far fewer people and received much less attention. Doctors, especially those serving in the military, did describe many cases of heart disease. And so if you read through the pages of the Indian Medical Gazette, which was one of the most prominent medical journals published in India in the 19th century, you can find unmistakable accounts of people who died from heart attacks or who were clearly suffering from coronary artery disease. And you can also find doctors describing another problem, which was really unique to India, called a flabby heart. And this they saw was related to India's heat. People who lived and worked in such a hot climate somehow developed a weakened heart. And this undermined the ability of Indian soldiers and Indian workers to exert themselves, or at least they couldn't work as hard as the British colonial regime wanted them to work. And this was part of a broader colonial discourse about disease, race, and masculinity. One of the most interesting debates that took place in the late 19th and into the 20th century was about rheumatic heart disease. Rheumatic heart disease is now recognized as an autoimmune disease that comes from your body's response to a common infection, strep throat. So some percentage of people who have strep throat go on to develop severe and even fatal heart disease. Now, in the 19th century, when rheumatic heart disease was first recognized, it was seen as a disease of cold, rainy places, places like England. And English and Indian physicians argued for a century, really from the 1840s into the 1940s, about whether rheumatic heart disease could even exist in the tropics in places like India. And we traced through this debate, and there were scores of articles that were published. And one thing that becomes clear is that the physicians were confounded by the complexity of India's environments. Even this question of was India a tropical place or not was a confusing question because India, as you all know well, spans everything from the alpine summits of the Himalayas to the tropical mangroves of Kerala. It wasn't until the 1930s that Indian physicians produced decisive evidence that rheumatic heart disease did exist in India. And by the 1950s, just 20 years later, Indian cardiologists were actually arguing that rheumatic heart disease was unusually severe in India, and complications from the disease occurred earlier in life in India than it did in Europe. And they start describing this new problem called juvenile mitral stenosis, so juvenile heart disease that was really seen in India and not in Europe. The disease began to get more attention in the early 20th century. In the 1920s, you begin to see the first obituaries in the Times of India of Indians who died of heart attacks. And one of the most puzzling pieces we found was a 1951 movie produced by a prominent Marxist director, Zia Zarhadi. The film, Humlog, tells the story of a family beset by poverty. At the climax of the film, the main character, Raj, shown here, delivers a rousing speech denouncing the unfairness of Indian society and the cruelty of people towards each other. And as he finishes his speech, he clutches his chest. You can see his fist here against his heart, winces in pain, and falls dead. Now, this classic image, a man at a high state of emotional arousal, clutching his heart and dying, was the classic image of a heart attack in Western literature and film. But in this case, it was expected to be recognizable and meaningful for the film's working class audience in 1951, at a time when most doctors still thought that this kind of heart disease was very rare in India. And so there's this disconnect between the medical literature and these popular films. And so one thing I've been curious about is why physicians seem to have been slow to recognize the onset of coronary artery disease in India. And you can see that in many places. When a doctor in Bombay completed one of the first large surveys of heart disease in India in the 1940s, he reported that coronary artery disease was much less common in India than in other countries. And he wondered if there was something about the life of the Hindu population of India that was protective. And he speculated that it might be because of their diet or their supposedly placid disposition. And so you can see here, as with rheumatic heart disease, now that the physicians were focusing on coronary artery disease, there was still a persistent racial discourse about the nature of heart disease and risk in India. Now, the situation with heart disease, or at least doctors' perceptions of heart disease, changed very quickly in the first decade after Indian independence. By 1955, that same cardiologist who thought that coronary disease was rare in India wrote often about the growing menace of coronary artery disease in India. And this disease was seen as a particular threat to the emerging economic and political elites in India. As Vakil wrote, coronary disease had a special affinity for members of the medical legal professions high up on the ladder of success. And so the disease was seen as a particular threat to the people who were considered the most important people for the future of the country. Now, any doubt about the risk of heart disease in India was shattered in May 1964 when Nehru collapsed and died. In retrospect, it seems that he most likely just died of a different disease, an aortic dissection, but it was widely reported in the newspapers, both in India and around the world, to have been a death caused by a heart attack. And in this case, what mattered most was the public perception. It was clear from his death that heart disease was a threat to the political leadership and the future of India. Nehru was succeeded by Lal Bahadur Shastri, and less than 2 years later, he died, again from a heart attack. Now, in the 1960s, Indian epidemiologists start publishing more extensive studies of the problem of heart disease in India. And many of these were modeled on the Framingham Heart Study and other prominent American and English heart disease studies. Now, the Indian studies sometimes produced surprising results. The Framingham Heart Study in the United States had identified the familiar risk factors: diet, exercise, cigarette smoking, and family history. But physicians in India said that these risk factors did not explain the risk in India as well as they explained the risk in the United States. Researchers, for instance, were puzzled by the high prevalence of heart disease among populations in India who were not smokers and who were vegetarians. And so, just as rheumatic heart disease researchers had been confounded by the diversity of India's physical environment, coronary artery disease researchers were confused by the complexity of India's diet and other kinds of risks for disease. Now, to wrap up this first part of the talk, I want to mention three things in passing, and we can discuss them in more detail. So, even though the dangers of cigarette smoking were well documented in the United States and England by the 1960s, the Indian government was slow to mount successful campaigns against tobacco use, really not until the late 1990s or early 2000s. And these were campaigns that Kavita actually had worked on at an earlier stage in her career. Second, even though the risk of air pollution to cardiac health was well documented in the United States in the 1980s and 1990s, the link between air pollution and heart disease still gets relatively little attention in India. This may actually be a major risk factor for heart disease now in both rural and urban India. And then third, while our work focused on heart disease in India, there has also been a fascinating debate about the nature of heart disease in the Indian diaspora. Beginning in the 1950s, researchers have published reports showing high rates of coronary disease in Indians living in Singapore and South Africa, in England, and the United States. Researchers remain confused about what the cause of this apparently increased risk might be. And part of the problem is that in these research studies that are done in other countries, South Asians are often lumped together as a single group of people. But as research has shown, South Asians are not a homogeneous group, either in terms of genetics or in their exposures to various risk factors. And this remains a puzzle and an active area of research and debate today. So now let me introduce my collaborator, who will offer her thoughts about the story so far. So Kavita Sivaramakrishnan is the Ronald H. Lauterseen Associate Professor at Columbia University and co-director of the Center for the History of Public Health. Her research examines medicine, global health, and disease politics in South Asia. She has authored As the World Ages and Old Potions, New Bottles, with new books forthcoming. She has led research collaborations with India and worked on heart disease prevention with the Public Health Foundation of India and with other partners. Until recently, she funded the Yusuf Hamid Research Fellowship Program with the Cipla Foundation between the Mailman School, Columbia University, and India, located in the Global Center in Mumbai, and focused on addressing Indian-based public health research challenges. So let me turn it over to Kavita.
Thank you, David. That was, I think, a really good entry point for us to begin a discussion about our book. So I want to kind of go back a little bit to tell people who are in the audience as to, what really brought us to some of these questions. And it's a bit of a puzzle when you think about heart disease itself. It can mean many things, right? When we think about what is the heart. In lyrical terms, if you look at Urdu poetry, the heart is where, is a seat of emotions and other things. But we were really approaching this from a framing of trying to look at it in terms of what is the framing from a biomedical perspective. And what did it really mean when we think about the heart, which is, of course, not a unitary category. It's fundamental. As we know, it's kind of, it needs to beat efficiently. It needs to pump blood. But at the same time, there are several kinds of diseases relating to the heart that have been recognized historically. And I think what really interested us is what are the different ways through, especially in our early chapters, through the 19th and 20th centuries, how heart disease began to be identified specifically with certain populations, and what did it mean to find heart disease in India itself, or the discovery of heart disease, especially for British colonial administrators. So I think to start with the first comment that David made when he showed you the slides about the plague, I think they're interesting because it relates to the formation of what was seen as a medical paradigm and a medical research paradigm that was located in the colonies, which was called tropical medicine. Now, tropical medicine was premised on the notion that certain kinds of tropical climates had certain kinds of taken for given constitutions. And these are the kinds of diseases people suffered from. So, of course, when the British were in India, especially through the kinds of research that started in British laboratories through the 19th century and 20th century, what they expected to find was that amongst what was seen as backward populations, you would generally find infectious diseases. And diseases of civilization, or diseases that were there in more advanced industrialized societies, were diseases like cancer and heart disease and other things that you would find in Europe or late in the 20th century in the US and other places. So I think the interest really came, and I think this is to respond to David, partly because of this interest in tropical medicine and its focus on infectious diseases, but also an interest in the health, particularly not of Indian subjects, but the health of the Indian army. And a lot of, the saying was that the average British soldier would survive only about 3 years in the Bengal monsoon. And so the cost of a soldier was very high. They focused on diseases like malaria and tuberculosis. But very soon, I think, we see in the columns of the Indian Medical Gazette reports that not only the British soldier who was drinking too much, eating too much red meat, who had heart disease, and therefore they had to compensate them through pensions. There was also the case, for instance, David, if you remember, the case of Edward Hodge, who served in the Indian Medical Services in Hong Kong, moves to Calcutta, and Hodge focuses on diet and physiology in the tropics, and he really focuses on the Indian sepoy. And he says that the Indian sepoy has a higher pulse rate. It's possible that the cases of heart disease that exist in the military are due to the native drill inspectors who overwork the sepoy far too much. Is it possible, perhaps, that the sepoys carry the load on their chest rather than their backs in the ways in which the English soldiers carried their equipment? So there's a way in which I think the discovery of heart disease itself didn't really come out of a huge interest in the health of citizens, in public health itself. The roots of it really came through the army, came through understanding how to maximize the efficiency of labor, whether it was Indian sepoys in the Indian army or whether it was an interest in terms of labor in plantations or other places where you would often have reports of workers who suddenly stood and died of heart disease. And then, of course, I think, as Davis was mentioning, the interest really related initially to rheumatic heart disease itself, right? The notion of trying to understand whether it was possible to have rheumatic heart disease in the tropics. And this became a very, very complicated question because India had so many kinds of climates. You wondered whether if you would get rheumatic heart disease in India, whether you brought it from other places, whether it could happen in the hill stations versus the plains. But it was very clear by the 1930s, I think, through most of the research and the people we've been looking at, that there were cases of rheumatic heart disease and rheumatic heart that were widely prevalent. And they were also rooted very much, not simply in Europe, but basically the disease was related to and anchored by the mid-20th century. It was clear that it was prevalent, especially amongst children and young adults. And it also struck Indians earlier in life, as we mentioned. And there was a famous case study in the 1930s by two researchers, Hughes and Yusuf, who were based in Lahore at that time. And they produced some of the most interesting papers. So I think one of the things that one of the facts that we do want to bring about is that our research has brought us down to thinking about very interesting and fascinating collaborations that existed in Indian medical colleges, Indian medical hospitals, between British researchers and Indian ones, between the Rockefeller Foundation and municipal hospitals in Bombay. So you see really how the making of a new medical of a new focus on cardiology, the making of a new kind of medical professionalization really emerges very strongly from these kinds of collaborations that existed at this time. And then I want to comment on a very interesting aspect that David brought out, really, which is popular culture, which is that is it possible that popular culture, particularly movies, were maybe a little bit ahead of the curve of the recognition that heart disease was quite widely prevalent in India, particularly coronary artery disease, that it was widely prevalent in India. And I think you bring out, David, the movie, which is the Zia Sarhadi movie, where you see actually the daughter Paro in the movie has tuberculosis. The eldest son suffers from heart disease, and he's a working class person. And in the end, he rubs his chest and says, basically, he talks about the law. He talks about his heart, but he also speaks about heart disease and class. The fact that he has been mistreated as a worker. So you can see kind of the embedding of heart disease in popular culture as being rooted really in socioeconomic circumstances. And I was also thinking there's another movie which I think our audience will know well, which is the movie Andaz. It was released in 1949 by Mehmood Khan. It's one of the few movies that actually had Raj Kapoor as well as Dilip Kumar in it. And there too, you have a different class angle, which is the typical one that is brought out often in Bollywood, which is that a wealthy father and a wealthy and disapproving father, when the heroine is having is melting towards Dilip Kumar, the actor, basically their romance is ruined halfway by the wealthy father having a heart attack. So that, of course, is what Rustam Jal, Vakil, and others were trying to say, as David was saying, that it's that heart disease was associated often with it was conceded that it was relating to to wealthy professionals. It had been associated definitely with the death of prominent Indian politicians, and it's really at this time that both the movies as well as cardiologists are beginning to really speak and analyze how widely heart disease is being reported at this time. But what is really unusual is, despite of all of this reporting, despite the fact that even in the 1950s and 60s, you see a growing awareness and the emergence, I think, especially in the 1950s and 60s, of a specialty, government policy, and this is what I discovered when I worked with the Center for Chronic Disease Research in New Delhi, that the policymakers came to this very late. And this is really quite surprising because though curative care for heart disease began to be introduced, the state entered the arena, especially of prevention, and also recognizing national heart policies much later because they saw it really as a responsibility of individuals and their lifestyle and certain kinds of choices that were being made. And that's something I think we also bring about in our book. David, I'll invite you to step back in so that I can comment on something else that you want to say.
Let me go back to showing the slides,
Yeah.
because my comments in the second half of the story pick up well on where Kavita just left off. Okay, so the slide should be back up. So as I said at the beginning, the second half of the talk will focus on this development of responses to heart disease and this mix of prevention and cardiac care. And just a brief disclaimer at the outset, for a variety of reasons, as Kavita had hinted at, we've focused here on the responses to the growing heart disease problems from Western medicine, from the medicine that was introduced by British and then later American doctors into India. There's much that could be said about how other medical systems in India have responded to this problem, but that would be a different project. And so that's not the focus of our research or our comments today. So if you go back to the 19th century, when our story begins, when there are initial reports of heart disease in India, there were no cardiac specialists in India, but to be fair, the specialties of cardiology and cardiac surgery did not exist anywhere in the 19th century. These are both creations of the 20th century. You do see physicians in the 19th century who begin to be focused on problems of heart disease. And so you can see textbooks like this that explore diseases of the heart, and in this case, with special reference to the diseases in India. And what would often happen here is a British physician would spend several decades in India, retire, move back to London, and then publish these books reminiscing about their experiences about the diseases they had seen in India. But again, very little focus on the actual treatment for these people. When writers discussed caring for patients with heart disease, it was often part of a rhetorical strategy that emphasized the lack of care that was available. And so, for instance, we came across accounts from Vellore in the 1920s, what is now the Christian Medical Center in Vellore, of people visiting the hospital wards, and they would come across children who were crippled either by rheumatic heart disease or congenital heart disease. And these narratives talk about these poor, innocent children who are suffering, and there was nothing that could be done for them. And this trope of suffering children, suffering Indian children, was used by these Christian missionaries both to justify the need for mission hospitals and then also to recruit donations from philanthropists in England and the United States that would support the work for these Christian hospitals. So it was a very manipulative use of this imagery of sick children for whom there was nothing that medicine could yet offer. Now, the situation of heart specialists begins to change in the 1930s. And you see the emergence of a community of doctors who are focused on heart disease, mostly in Calcutta and Bombay, but you can see heart specialists, self-identified heart specialists in other cities as well. And many of these doctors had managed to travel to England to receive some advanced training in London before returning and establishing their careers in India. And so in the late 1930s, cardiology is on the verge of emerging in a concrete, specific way in India. But then World War II starts, and the war disrupts everything, even in India. And even though India saw little actual fighting, there was a massive mobilization of the Indian economy and the Indian military to assist with the broader war effort. Many Indian physicians were drafted into the British Army and served, especially in the brutal fighting of the Burma campaign. And the war also sent many English and American physicians to India. This photograph here of the 20th General Hospital was one of the large American hospitals that was built to provide support for the project to build the Ledo Road into Burma. And doing this work where you have Indian and European and American physicians working side by side establishes a series of connections between these people as individuals that prove important to the development of cardiology and cardiac surgery after the war. And so you can see in the first decade after independence, the rapid emergence of both cardiology and cardiac surgery in India, as well as in England and the United States. And again, for a variety of reasons, mostly related to which places had good archives, but not entirely for that reason. We focused on two important sites to trace the development of these fields. The first was the Christian Medical College in Vellore. CMC was established as a mission hospital in 1900, and it soon became known for its expertise in surgery, especially for gynecological problems and for leprosy. Now, World War II created a financial crisis for the hospital as the people, the philanthropists, the donors who used to send money from England and the United States were now preoccupied by the war effort in England and the United States. And so CMC lost a lot of its donors during the war. And so the hospital leadership decided to pursue a new policy of trying to attract patients who could pay for their care. And the strategy was that if the hospital developed medical and surgical specialties, people would come from all over India to seek this specialty care at Vellore. And to do this, the hospital leadership selected a small number of physicians and surgeons to send abroad, now mostly to the United States, for advanced training in both cardiology and cardiac surgery, and also neurosurgery and some other specialties. And this investment pays off. And so surgeons in Vellore made history in July 1961 when they completed the first successful open heart surgery in India. A second important site was King Edward Memorial Hospital in Bombay. Now, this had been a municipal hospital established in 1926 to prepare care for the workers, the textile workers who lived in the mill district of Parel. And this was an interesting place. It had a mix of private and public practice for the physicians, and this facilitated the emergence of specialists, first in cardiology in the 1950s with Rustamjal Vakil, and then with cardiac surgery in the 1950s, especially with P.K. Sen. Now, KEM and Vellore as well benefited from substantial support from the Rockefeller Foundation, which Kavita had mentioned earlier on. And this support allowed KEM to quickly emerge as one of India's leading centers for cardiac surgery. And KEM made hospital in February 1968, at the end of the decade, when a surgeon there, P.K. Sen, became the fourth surgeon in the world to attempt a heart transplant. Now, these achievements of India's cardiologists and cardiac surgeons were put on display in November 1966 when Delhi hosted the Fifth World Congress of Cardiology. Thousands of specialists from all over the world came to Delhi to share the latest and greatest stories about medical progress. The World Congress received enormous attention in the Indian media, and this served to raise the profile of heart disease in India and also to raise the profile of India's burgeoning cardiac specialists. Now, this work was not easy. These hospitals, especially the public hospitals and the mission hospitals, always faced constrained resources in India. And they often faced a difficult choice between providing basic care for as many patients as possible or for providing specialty care to a smaller number of patients. And even into the 1970s, many prominent hospitals, for instance, the All India Institute of Medical Sciences shown here, had only a very few positions for cardiac surgeons on its staff. And so these hospitals, especially AIMS, had a very prominent training program. They were training cardiac surgeons in India, but then they couldn't employ the graduates of their training programs. And so these graduates had to look elsewhere for employment. And they often end up stringing together part-time work across multiple hospitals as part of their effort to build a successful career as a cardiac specialist. And during this time, it was very difficult for them to keep up with the progress that was being made in cardiac surgery in the West, because very few cardiac surgeons in India were able to have a full-time practice of cardiac surgery. So in the 1970s, you start to see Indian cardiac surgery falling behind either with heart transplants or with the new technique of coronary artery bypass surgery that was rapidly transforming cardiac surgery in the West. Now, a key development here takes place in an unexpected place, the Perambur Railway Hospital near Madras. Now, the Indian railway system had an enormous patient population, millions of railway workers and their families. And of course, because it was the railway service, it was easy to transport these patients around India to receive medical care. And so the railway system decided to develop a few specialty hospitals. And Perambur was chosen as a site for cardiac care. So first, T.J. Cherian develops a basic cardiac program there in the 1960s, doing basic cardiac surgery. He then recruited K.M. Cherian and M.R. Girnath in the 1970s, and they invested in mastering this new technique of coronary artery bypass surgery. And by 1980, they had built this railway hospital into one of the best and busiest cardiac surgery programs in India. And so in the 1980s, when cardiologist P.C. Reddy founded the Apollo hospitals in Madras in 1983, he invested heavily in cardiology and cardiac surgery. He recognized that expertise in these areas would attract patients who could pay for care. One of his first moves was to recruit Giranath and the surgical team from the railway hospital to come to the new Apollo hospital in Chennai, or in Madras, and they quickly built this program into India's premier cardiac surgery program. And many other corporate hospitals followed this lead. Our key point here is that the success of the private hospitals in the 1980s depended on the prior success of cardiology and cardiac surgery in the public hospitals in India in the 1950s and the 1960s. The rapid emergence of corporate care in the 1980s was only possible because it could tap the kinds of expertise that had been cultivated in Vellore, in Bombay, and at AIMS. And of course, India now has some of the best cardiac care in the world, but it's still not accessible to all patients. And this is where the Lancet Commission starts to figure into this. This challenge persists today across many fields of medicine. And so, for instance, this spring, when medical experts in India and the United States published this Lancet Global Commission that called for people to reimagine India's healthcare system towards a goal of providing universal health coverage with a citizen-centric healthcare system, you can see the kinds of challenges that this vision will face. Heart disease, especially coronary artery disease, is the leading cause of death in India. Much, much more work will be needed before India has a system that invests heavily in prevention. Everyone has recognized since the 1950s that the best way to manage coronary disease is through prevention, but countries around the world have struggled to live up to this full promise of prevention. And then you're left with a very large number of people in India, tens of millions of people who have coronary artery disease. And how do you provide effective and timely care for these people? And this will require complicated work across both the public and private healthcare sectors in India. So let me stop sharing here, and turn it back over to Kavita for some comments, and then we will open it up for questions and answers.
Thank you, David. I want to kind of first look at some of the actors that you've mentioned because they're all fascinating. When you look at the case of the medical missions, for instance, I think we've made several trips to Vellore, especially I've been in touch with the archivist in Vellore, looking at the rise of Christian medical missions. Christian medical missions have often been associated really with treating, uplifting poor people, looking at community medicine. But there's a really very important historical conjuncture and dilemma that comes up for the medical missions in the 1940s, which is the rise of national churches and trying to figure out what is the position of Christian missions in an independent nation, right? What is a post-colonial mission that missions like the Vellore Medical College could have? And that's the point when they realized that the kinds of training they were doing are not acceptable anymore. The licentiate degree, for instance, is something that comes into question at Madras University. And that's when people like Ida Scudder, who are heading the enterprise at Vellore, begin to think that maybe this is the time to open this hospital up to certain kinds of private patients, to build a private medical specialty, and make a case really for medical missions to have a role not simply in their older association, which is to be associated with evangelization, with a range of, with uplift in communities, but also to see themselves and give themselves a very different profile. So I think what we've tried to argue is that the rise of certain kinds of professions, investment in certain specialities, have also come very importantly with certain social and political choices that our actors have had to make. And that really is the story of how Vellore becomes this really critical medical mission. We've interviewed patients who were treated there. And the rise of Vellore is linked with some of the most famous, like Nagarur Gopinath, cardiac surgeons who were recruited to Vellore. They were trained by an American surgeon called Reeve Betts. And then you see the circulation, which I think is really fascinating, which is Nagarur Gopinath is trained as a cardiac surgeon in Vellore. And then he moves from there to the All India Institute of Medical Sciences and is recruited there. So you see the circulation not only of training, but also of individuals who take it from place to place. And so let me give you the example of another kind of post-colonial circulation, which is that when you look at the kinds of dilemmas that India's politicians and scientific elite had, the key question really in the 1940s and early 50s was, what are the kinds of medicine and science that a new and young Indian nation should really prioritize? And for most people, especially after the Bohr Committee report, it seemed to be clear that infectious diseases, the poor quality of treatment and care was really important, but also the setting up of hospitals, taking up eventually and planned towards non-communicable diseases or chronic diseases and other kinds of priorities. But what was really clear is that the Indian middle classes and Indian political elite were very clear that they needed to catch up with a kind of technological lag. And I think it is this kind of leapfrogging of wanting to catch up with certain kinds of cardiac surgery, with really needing to catch up and stay ahead and be a post-colonial nation that was not only known for treating diseases of poverty, but also would be associated with technical advance that really seemed to be able to make both a middle-class readership in the Times of India, as well as these politicians to decide that, we can invest in resources in medical specializations that actually are associated with industrialized nations. So I think the core of the book and the question we grappled with is, how can you justify a high resource focused medical specialization and its development in a nation that was just coming up and grappling with questions of food insecurity, famine, wars with its neighbors in the 1940s and 50s? How do you really justify this kind of tension? And as historians, that was really a question that fascinated us, to be able to see the justifications that both experts made, the kinds of rhetoric they invoked, for instance. I think what's very interesting is most Indian cardiology conferences start with cardiologists not only making a reference to biomedicine, but they also invoke an older history of Ayurveda, of Shushruta and Charak and others who actually were linked, who knew the art of reading the pulse, for instance. So there would always be a linking back and forth, a justification of not only a recent past, but an ancient past that could be invoked to be able to justify the taking on of a modern medical specialty. So on the one hand, you have biomedicine, but you also have the politics of certain kinds of indigeneity. And I think definitely a very, very assertive politics of being able to say that this is not just India borrowing from the West, but there is a rhetoric of self-reliance at the heart of, for instance, in the 1970s and 80s, when there's an import-export substitution, there's a range of kinds of stringency that are happening in India at that time. At that point, people are actually trying to see what kinds of bricolage can be done to be able to have certain kinds of technology that are manufactured between the steel factory that manufactures pipes for PK Sen in Bombay, that is the Godrej steel factory, to others who are actually chipping in to be able to say we can actually put together certain kinds of technology that are both imported but also have a life and afterlife in India based on being produced through these networks. So what we found really fascinating is that when one of them would actually, for instance, when PK Sen would in the theater in KEM Medical College, when he would actually perform a surgery, many others who were partly competitors, partly collaborators would come to watch him. So there's actually an entirely different network, which is both the Rockefeller Foundation in India, but a network between medical colleges, between Vellore and the All India Institute of Medical Sciences, between the All India Institute of Medical Sciences that's being closely observed with smaller centers like in Amritsar, in Chandigarh, and other places that are also coming up with their own programs. And on the other hand, within cities like Bombay and Delhi itself, where you have this kind of veiled rivalry, which is very interesting, between Kursi Dastur, who is in Bombay and who is watching what PK Sen is doing. And at the same time, you have people like, you have the All India Institute of Medical Sciences, but you also have cardiology programs that are coming up at the same time in Maulana Azad Medical College in Delhi. You have a notable figure called Padmavati Sivaramakrishnan, who I share a name with, but I'm not related to her, who is really a stalwart in putting up her own kind of linkages with people like Paul Dudley White, and she becomes a key figure in initiating the in one of the key organizers in the World Cardiology Conference in the 1960s that is held in Delhi. So I think the narrative is very interesting that we are trying to kind of narrate, put through to you here, which is that on the one hand, this is a story really about what is the nature of science and medicine that emerges in a post-colonial nation. What are the dilemmas that experts face? What are the kinds of ways in which what are the ideas they use to justify? How are the ways in which they can understand and interpret and translate the kinds of diseases? How does history and invocation come into this? And also this really important question: how are we able to trace the making of a specialty which starts in centers like a medical missionary center in Vellore, which is many hours away from Chennai, and from there to public hospitals like the All India Institute of Medical Sciences, to railway hospitals like David brought out in Perambur, where you have Girinath and others and Cherian and others who thrive there. These are people who've been trained abroad. But there's, it's the reverse story of a certain kind of brain drain, which I think, colleagues in David's department whose work I admire hugely, like Iram Alam and others have brought up, which is really that why do people who've been trained abroad in India, who've left India in the 1940s, still return to these institutions? And Cherian has a fascinating story. When he comes back to Perambur, he comes back from Australia and decides that he'll have a career here. So I think for many of our listeners, this is also a story of how experts really set up a profession and what attracted them to come back as certain kinds of pioneers in setting up a medical specialty when they didn't have ideal conditions. Many of them, Cherian says he was running behind, he was running in his lungi from his accommodation to doing emergency surgeries. There was a range of people. There were nurses who came from Vellore to be able to help him in Perambur and traveled over the weekend. So this is really a very fascinating narrative of how you don't have to have the ideal circumstances to kickstart certain kinds of operations. You actually have a range of partnerships and collaborations and very much competition as well between all of these experts. But I think the story really interested us because of that, David, isn't it?
Yeah, but one question I want you to say more about is this question of gender. In the United States, cardiac surgery and cardiology were the epitome of male-dominated medical specialties. There are very few women in cardiac surgery
Right.
in the United States, and certainly in the 50s, 60s, and 70s, I don't think there were any prominent women in cardiology, or with one exception at Hopkins. The story we found in India really foregrounds the role of several very prominent Indian women. You'd mentioned Padmavati, Kamala Vaidyanathan at Vellore. In the 1970s and 1980s, a cardiac surgeon, Ratna Bagotra, was one of Dastur's students in Mumbai. What do you make of the prominent role that women played in India in contrast to the situation in the United States?
I mean, let me take the example of Padmavati Sivaramakrishnan. I mean, clearly they had the benefits. Padmavati was from she's an upper caste Tamil Brahmin. She also is educated, very, thanks to a father who was she has had her share of trauma. But I think what is interesting is that there is Padmavati and others are able to compete in a world based partly on certain kinds of social self-confidence that they get from their training. But they're also very scrappy and they're able to do something in India at that time because I think what they do is use I think they use male cardiology figures in various arenas and at various levels to their own advantage. When it suits Padmavati Sivaramakrishnan, just to tell the listeners, has a fascinating narrative that ties up to what David was talking about in the 1940s in Burma. When in 1941 the Japanese Navy bombs Singapore and then the siege starts around Burma, Padmavati is in a medical college I think in Rangoon. Her family escapes from there, like a lot of Tamilian families, and she moves back to Coimbatore or Madras. She gets trained there and then moves, and then she's trained, of course. I think, David, she was trained with Helen Taussig, was it in Hopkins? Yeah. And she trains with Helen Taussig and then sets herself up. She sets a clinic up in Delhi and thrives in Maulana Azad Medical College. So she doesn't seek to go into the All India Institute of Medical Sciences, which is already a place which is dominated by Sujoy Roy and others who are, it's already a well-formed kind of department. So I think people like Padmavati choose to set up a fresh kind of center of power. She also collaborates with the private agencies like the Times of India that fund the Heart Institute that she sets up, which still exists near Greater Kailash in Delhi, which I went to a few months ago. And so I think there are several strategies of having partnerships that are international. She's very close to Paul Dudley White. She has a few private partners in Delhi. She works closely with the All India Institute of Medical Sciences, but still never totally sees eye to eye with Sujoy Roy. So I think when it comes to people like Padmavati, they certainly use questions, there's the privilege of definitely class and her education. But at the same time, it's a very, very difficult life trying to compete in such a hugely male-dominated profession. And I think when I went recently to the Heart Institute in Delhi, we looked at a range of pictures that that are still collected there from Padmavati's archive. And you can see that for every inauguration that happens of a cardiology clinic, she turns to political figures like Indira Gandhi. And I was told that she's in touch with Indira Gandhi, who says, you're inaugurating a clinic. I will even postpone my speech in Parliament if it comes to coming to inaugurating the clinic for you in Delhi. So I think she also makes networks at that time with prominent Indian women political figures, including with Sushila Nair, who's the Minister of Health. So there's a range of I think, of collaborations and networks that women cardiologists have to make. And in many ways, to lead singularly difficult and lonely lives. Padmavati never marries. She becomes the institute becomes her life. So in many ways, there's a huge range of sacrifices that come up to and that cost. So just to respond to that, David, very quickly.
And there was someone who put a question into the Q&A, and if other people have questions, feel free to plug them in. And Kavita, this is a question you're much better suited to answer than I would be. Would you compare what happened to mission hospitals with what happened to the minority, mainly Christian schools, or at least to their elite service functions? Was there a parallel between what happened to the mission hospital and what happened to mission schools,
Yes, right.
especially their elite service functions? Yeah.
Yeah, I think, well, that's an interesting question. See, there's a succession of things that happens with the missionaries. The missionaries move to medicine after they've had a range of problems with missionary education. Missionary education starts much earlier in India in terms of missionary schools that are set up. Initially, of course, to be able to teach English to an aspiring middle class. And when missionary schools become missionary education is what the missionaries enter first. And when they do, with the rise of the Arya Samaj, Singh Sabha, and a range of others who feel that they can also take over education, these are the big reform kind of movements that start in Bengal and Punjab and UP in the 19th century. It's that moment when the missionaries then say maybe the ministry of healing could be an advantageous way in which Bible reading in the clinics could happen. The Ludhiana Medical Mission starts with Bible reading in the clinics. Maybe people could be healed and maybe we could evangelize. But by the time they reach medicine, this is a discussion David and I have had often before. I think it's clear that they're not making the kind of inroads they thought they would with evangelizing that they had with education. It certainly doesn't have the same kind of power. And medical missions then really start to be able to consolidate a position rather than to expand medical missions, the what's it called, places like Vellore that had missionaries. So I think education precedes medicine. And once they start the medical missions, it's something that doesn't really help them to expand far wider. And they raise money initially through their contacts in the US and the UK. But increasingly, this question of self-sustainability and survival comes up, which is why I think the cardiology program at Vellore becomes really crucial.
I just got a question from someone else in the audience, from Tarun Khanna, about the extent to which cardiac care in India developed special techniques, perhaps in response to this question of surplus labor and relatively scarce capital. And he invokes the experience of Devi Shetty, who founded Narayana Health in Bangalore in the early 2000s. There are many interesting stories about that. We had mentioned briefly, there was this problem that these people faced in the 1950s. If you were a would-be cardiac surgeon in India, at the time, the field depended on technologies that had been developed in the US and Europe, especially the heart-lung machine. And for a variety of reasons, the Indian government was pursuing a policy of import substitution industrialization that made it very difficult for Indian physicians to purchase equipment from abroad. And there were limits on foreign capital or foreign currency exchange as well that made this difficult. Part of the reason that KEM and CMC rise to the fore of this field of cardiac surgery in the 1950s is because they had support from the Rockefeller Foundation. They could use Rockefeller money to buy equipment in the US and then ship that into India to bypass some of these import regulations. And it was especially easy to do for the mission hospitals because they had special dispensations that allowed them to import supplies without tariffs. But there was never enough material. And so one of the most interesting characters we came across was this guy, Kirsi Dastur, who was a physician at a different hospital in Mumbai who didn't have access to Rockefeller capital. And so he does, what we could describe as the scrappy entrepreneurial thing. He had a brother who had worked for Godrej. He got introduced to several of the engineers there. He designed his own heart-lung machine, works with the engineers. They tinker with it a lot. The first times they use it, it's a disaster. They go back to the drawing board. They rework this machine. and quickly come up with a viable model produced within India. And you see an exchange of letters that play out in the Times of India in the early 1960s, where the KEM hospital was more or less criticized for relying on imported equipment, whereas Dastur was valorized for using an indigenous machine. And that he got credit in the press for using Indian-made devices. And you see this tension running through. That said, the technology remains very expensive, and we've talked to a number of surgeons who would tell their stories about how they would try to get by given these constraints and scarcity. And so I spoke to some surgeons at the cardiovascular center in Pune, at the military hospital there, and they described how early on they would reuse a heart-lung machine from one patient to the other. So they would get three patients who all had the same blood type, and they would use the same heart machine apparatus for these three patients, one after the other. And surgeons in the United States would say that's wildly dangerous because you're exposing people to blood from other patients and you could get transfusion reactions. And the Indian surgeons would say, we had to do this. Because of the expense of these techniques, Indian surgeons are really on the forefront of developing ways to provide cardiac surgery without using heart-lung machines. And so there's been a major debate in the United States about what percent of cardiac surgery can be done on a beating heart. Technically, it's very difficult to do this, but it's possible. And so there was a great interest in beating heart surgery in the US in the 1990s. And for the most part, cardiac surgeons in the US have decided you're better off using a heart-lung machine. And so something like 75% of cardiac operations for bypass surgery are done on a heart-lung machine in the US. So most bypass surgery is done on a heart-lung machine. In India, it's the opposite. The surgeons there now do 95% of their operations on the beating heart. And they say, because of the scarcity, we have figured out how to become technically more proficient surgeons so we can do the more difficult operation and still get adequate outcomes. And there are major debates in the medical literature about what's the cost of doing this. So they're very interesting back and forth between, what's the best situation, what's the best way to get by in conditions of scarcity, what's ideal for patients versus what's ideal for a broader healthcare system of limited resources. So a very, very interesting question.
I want to briefly add to that. I think, Tarun, this question is interesting also because I think this question of scarce capital is the other side of it is, of course, the surplus labor question. And I think many of them said actually that they, including Girinath, who was based at the railway hospital, he's one of the first, he's a cardiac surgeon who moves, recruited initially to move to Apollo. He says they were able to have enough capital at least to be able to hire cheaper labor. He had a team of 30 or 40 people that he built up at the railway hospital. And when Apollo was set up in Chennai, he's able to move with all of them and they get recruited to go to other places. And remember, it's not so expensive to be able to attract a surgeon who's working at the railway hospital to some of the private hospitals that are coming up because government salaries were quite low. So many of them are actually willing to make this move from the public to the private. And some of them in the interviews that we conducted in Chennai, one of them told me that it was a huge dilemma. He comes home and he says he's going to move to the Ramchandra hospital, which is set up a little bit outside Chennai. And his whole family says, why would you leave a public hospital with a pension to be employed in a private hospital, which will pay you more, but is much more precarious. You have longer hours. There's a whole different kind of corporate culture to where you'll move. So I think the unsaid story is also what does it mean for individuals to work in a public arena? And we think it's easy for them to move to something that is private and corporatized and efficient, but it also means a huge change in lifestyle. It doesn't necessarily mean that they're paid so much more initially when they move. So I think labor costs itself continue to be cheap, relatively, even when it comes to the payment not only of assistants and others, but also of surgeons. And I think that's something important to kind of keep in mind in the Indian context.
I also, looking at the clock, I realize our time is up. There's obviously much, much more that could be said about this, the challenges that India and really every country in the world faces. on how best to manage the enormous epidemic of coronary disease that strikes down, is the leading cause of death worldwide now. And many countries have invested major resources to try to get ahead of this epidemic, but I don't think there's anyone who could declare victory, even close to declare victory at this point. And so this is a problem that will require the attention and the creativity of many people across many different fields. There's obviously a space for medical innovation to try to develop new techniques. And there's a lot of work to be done by social scientists and by business experts and by experts in healthcare delivery to try to figure out, what are the best ways to deliver the care that we already have. And then, of course, this question of prevention that will always be the holy grail. It is very easy to imagine a world in which there was no coronary artery disease. It's not some innate thing that happens to humans. It's what happens to humans who live in certain kinds of ways and with certain diets and certain behavior patterns. It could be entirely prevented, but the challenge of realizing that future without coronary disease is an incredibly difficult one that will, I suspect, preoccupy people for decades to come. So thank you very much for your attention. If you have questions, feel free to reach out to either of both of us and would be happy to respond that way. So thank you.
Thank you. And I also want to briefly do a shout out to one of the people who's informed our research, Professor Srinath Reddy. Especially since David's talked about prevention. I think some of the earliest campaigns for prevention have been linked to cardiology and tobacco. We are very happy to address some of that too. And that's actually the case of the dog that did not bark, or what did not happen. Why was it that really prevention, and especially prevention, gets tied up to tobacco campaigns? But really, why does cardiac prevention get shadowed by this very early successes and the costing that happens to cardiology, cardiothoracic surgery, and the lack of preventive campaigns, which I think has been a big dilemma, which we are happy to address also. Though I do think there's some very important work already being done on the ground, which we are very happy to discuss. So thank you again, and thank you for inviting us. And please stay tuned as our book comes out, and we will stay in touch with you as well. Thank you.